And welcome back to African Perspective with me, Aldrin Simpier. They form the majority of the frontline workers, but the United Nations has lamented the trend in several countries where women's voices are being muted during the COVID-19 pandemic. Our foreign desk editor, Sophie Mokoena, spoke to two WHO officials, Dr. Diaz as well as Dr. Maria van Kerkhove, about their careers as part of senior WHO officials and how they handled the coronavirus.
I am an infectious disease epidemiologist, originally from the United States. I've been living abroad with my family for 15, 16 years now. In my area of work is mainly around emerging diseases, mainly respiratory diseases, but I've also worked with arboviruses like Zika. I've done some work with dengue and with Ebola, but I've mainly worked on influenza, MERS coronavirus, and now this coronavirus. I've been with WHO, working with WHO for more than 10 years in different capacities throughout my career. And I've spent a lot of time in the field. But I'm also a mom and a wife, and I have two young little boys that are here with me and my husband in Geneva.
Thank you so much, Doctor. Let's get Dr. Diaz.
So Dr. Diaz, actually, I'm the third Dr. Diaz. My father is Dr. Diaz. My older sister is Dr. Diaz, and I'm the third in the family to be Dr. Diaz. So I'm a pulmonary critical care physician. So my specialty is in pulmonary medicine and intensive care medicine. I have also from the United States, but was most recently living in the west part of the U.S., where I was working clinically full-time with consultancies at WHO for about 10 years, but still clinically active until about 2.5 years when I came to WHO to lead the clinical unit of the emergency program. So the focus here is on clinical response and readiness to emerging infectious diseases, including the respiratory infectious diseases like COVID and influenza, but also the hemorrhagic fevers such as Ebola. And it's my pleasure to be here. Thank you.
If one may ask Dr. van Kerkhove, what drove you to be, one of the people who are dealing with the issues that we are dealing with in terms of your career? What inspired you to take this route?
When I was a university student, I spent my summers abroad, part of my summers abroad, working with different groups of individuals who studied plants. In fact, medicine men, medicine women who used plants around them, and they used them to treat their communities. And I became really fascinated with this idea of treatment of infectious diseases using the plants around them, and why, and how did they know, and that knowledge base. And I just became interested in viruses in general, why they infect some and not others. That led me to some field work in Cambodia when I was doing my PhD with the London School of Hygiene and Tropical Medicine. And in Cambodia, I learned everything about One Health before it was called One Health, an emergency response, outbreak investigation, and this idea of people living with animals, living with these viruses. Sometimes they stay in the animals, sometimes they jump into humans. That fascinated me in terms of that detective work and these studies and investigations around that. And it drove me into a career and into some further studies in epidemiology. And I got involved with WHO in 2009, during the 2009 influenza pandemic, where I was embedded within the global influenza program supporting that response. And from there, it grew into what I do now, which is developing prevention and control programs around these emerging infections. And I work with amazing people like Janet, and I work with laboratorians, and we work with infectious disease specialists all over the world that are essentially part of our team, if you will, an extension of what we do to try to harness knowledge of these normally very rare pathogens. But I just love the idea of studying viruses and why certain people got sick and why others didn't, what we could do to study them and what we could do to prevent them.
Dr. Diaz, why did you choose to work for WHO?
So, I'm a clinician at heart, so I always want to think of patients. So I want to give patients the best care possible, the safest care. And, I was doing that for many years in the U.S., and then I started doing some work consultancies for WHO. And also in influenza, so around the same time as Maria. And in that, I started with training training clinicians in other parts of the world that were having more challenges in caring for patients and applying best standards, best practices in settings where the resources were more limited, more constrained. And in that work, I really just got inspired because for me, it was like, okay, we have this wealth of information on how to take care of patients. We still need to learn more, obviously, especially for COVID, but we do know how to do some things well. And that information needs to be shared globally, equitably to all clinicians so that all patients have the same access to care. And that is really what inspired me by the work with WHO. And then with the emerging infectious diseases, noting from what happened in West Africa, where it was like someone has a disease that people are scared of, and so that patient may not get all the care. The clinicians may be too scared to take care of the patient, the IPC, those things. And all of a sudden it was like, okay, no, we have to, even if you have an emerging infectious disease, a new pathogen, new patients should be able to get the best care, and clinicians and health workers should be able to feel confident that they can deliver safe care. So I think that is what inspires me.
Well, let's talk about WHO, your work at the WHO. If you were to share with us your experiences in terms of the support from member countries.
Everything that we do at WHO, whether we're based here in Geneva and headquarters, whether we're in our regional offices or our country offices, even in countries where we don't have country offices, everything that we do is meant to help individuals. It's meant to help people keep them safe, protect the vulnerable, make sure that we could prevent outbreaks from happening where we can, or if they do happen, to minimize their impact. And there's a whole slew of activities that WHO does. For me, one of the things I love the most about what we do, and I'm so inspired by all of our staff that we have here and the people that we work with, is our opportunities to do our field missions in the time that we actually get to spend in countries working with the people that we are meant to be reaching. And so I've been fortunate to go on many missions for WHO, for many different diseases, but mainly in the last couple of years, mainly for MERS coronavirus, throughout the Middle East, but also in several countries in Asia, where we are advising directly, the ministries of health, doctors who are caring for patients, surveillance officers, rapid response teams, people who are dealing with biological samples and lab issues, and really that one-on-one interaction of turning scientific information into recommendations into action. So it's one thing to develop a guidance material. It's one thing to discuss the science and say, okay, this would be ideal if we could do, but if it's not implementable in a country, it's useless. And so what we try to do is we take the information that we have, we generate these guidance materials, this advice, we work with countries to see how it can be implemented, and most importantly, to be sustainable. So the work that we try to do, maybe we go in for a specific outbreak or a specific reason, but the idea is to build a sustainable platform so that it stays in countries and that countries have that ownership and responsibility to deal with whatever may come for them. So some of my most memorable work with WHO are on field missions, where we're advising in the heat of an outbreak, where the situation is not completely clear, and where there may not be some certainty about what may happen, but we kind of break it down with them and we support countries to take that leadership role and to really deal with the outbreaks that they are dealing with.
Dr. Diaz, you also have your own experiences, and particularly in terms of the challenges. What are the challenges?
Thank you. So, there can be many challenges, I think, but I see them, as opportunities on how to collaborate and do better together. And I think the best example is probably, I spent quite a bit of time in Eastern DRC at the most recent Ebola outbreak. And as many of you may know, that North Kivu region is an unstable region with conflict for many, for decades. And so working in that environment was a challenge. But what I also learned there was this tremendous amount of solidarity, we can use that word, collaboration that is needed with the ministry, with all the international partners, with the other agencies, with the community, with the local clinicians, and only together can you do something better. And so what we were able to do in that outbreak was really improve the standard of care, the optimized standard of care for patients with Ebola, which meant that patients were receiving intensive care, fluid therapy, the appropriate electrolyte repletion. And these are details of clinical care, but it was something that wasn't done in a standard way during the other outbreak in West Africa. So in this setting, even though it was a complex setting, we were able to really optimize the clinical care that patients with Ebola had, and at the same time also implement a research study that found 2 life-saving therapies for Ebola. And so that piece of being able to implement that type of research in that setting, again, it was an incredible experience to be able to be one person that was helping to push this forward, to give access, to train doctors, to work with partners, to support the ministry and the National Research Institute in this work.
Well, let's look at the coronavirus and the outbreak of the pandemic. It was something that was not expected. Where are we currently? Are we winning the war, Dr. van Kerkhove?
Oh, Sophie, that's a really excellent question. I mean, I think this is something that many of us, around the world who study these types of pathogens have been planning for, have been saying may happen, have been warning about. And it was never a matter of if, it was always a matter of when. And so there are many systems that are put in place to prepare countries, to ready countries for something like this. However, no matter how much preparation you have, when something like this happens, it's very difficult to manage for many countries. And I think if you look at some of the countries and how they have responded, many of the countries that have done better than others, let's say, especially in the beginning, are countries that had experience with similar pathogens. If you look at countries across Asia that had experience with SARS coronavirus, the first SARS coronavirus, MERS in the Middle East, avian influenza, high pathogenic avian influenza in Asia, and many countries across Africa that have experience with infectious diseases, had systems in place for surveillance, for testing, even if testing capacity wasn't ideal everywhere, but had systems in place to look, and to be able to use what was in place strategically. Had contact tracing, knew how to do contact tracing, and maybe not have the most sophisticated hospitals. We would hear from many countries saying, look, we might not have the most sophisticated hospitals in the world, but we can do contact tracing. We can do active case finding. We can do clinical care. We can set up hospitals and repurpose hospitals. And so there was a lot of muscle memory that was across the world that was really kicked into gear. And the other thing is that many leaders who had experienced this before knew immediately this was not just a health issue. This was going to be above health. It was going to be beyond just the health sector and involve the finance sector and the education sector and travel and tourism. And so I think other countries are learning that now and are really learning from the experience that they had. Where we are now is a completely different situation than we were in 5 months ago, 6 months ago. We know so much more now in terms of how to deal with this virus, in terms of how to break chains of transmission and reduce the occurrences of clusters and outbreaks. We know so much more about clinical care and saving people's lives. And I will let Janet explain further on this because mortality rates are going down, and there are many reasons for that. But overall, globally, we're in quite a worrying situation. We have been working very hard with, over many, many years to work with countries to be prepared and to be ready for something like this. However, when something like this happens, it's a matter of activating the systems that you have in place. And we have seen in many countries that have had experience with similar pathogens like the first SARS coronavirus, high pathogenic avian influenza, MERS coronavirus, they have a muscle memory almost. Many countries across Africa who deal with many different types of infectious diseases have a muscle memory to activate systems that are in place. Surveillance systems, testing capacity that's in country, even if it's not able to test everybody that needs to, there's a system in place to use it strategically. Many countries have contact tracing systems that are in place or have experience with contact tracing systems, and all of that was activated very, very quickly. The other thing that we saw is that many leaders knew immediately that this would go beyond health. And so immediately engaged other sectors, education sectors, travel and tourism, finance sectors, to bring everybody together to say, this is what we need to do. Clear, consistent, honest, open communication, about what was going on, what we know, what we don't, and what you need to do so that communities felt engaged. And I think what is really important that everybody understands is that we're not in the same position that we were in 6 months ago. We know so much more now about how to break chains of transmission and to bring outbreaks under control when and where they occur. So using the system we have in place to make targeted interventions. We also know so much more about saving people's lives and preventing people from advancing from mild disease to severe disease and from severe disease to death. And Janet can explain this further, because there's a lot that we have, these tools that we have now that can actually save lives. And so we're not in the same position. And so I'm very hopeful that even though we are seeing increases in cases, because we have better surveillance that's in place, we are seeing increases in hospitalization rates and worrying trends in ICU rates. We can turn it around. We can work together to bring these outbreaks under control, but it will require a massive collective effort of everyone coming together, no matter what your background is or what your views are, coming together to fight this. All of us have a role to play.
Dr. Diaz, Dr. van Kerkhove spoke about prevent. You deal with critical care. Are we ready? Or are we doing enough?
It's a good question. And the answer is yes, but we still need to do more. So I think when the pandemic started, there was, again, like every disease, at the beginning, there's fear and there's also uncertainty. We don't know about the disease. We don't know how severe it is. We don't know how to manage it. And I think one had to, at that point, become a little bit practical in the sense and say, what can we actually do, even though we don't have a life-saving therapeutic? What can we do? We still can take care of patients. And that's where we started to emphasize to countries care pathways, the COVID care pathway. The COVID care pathway means that at the moment you suspect someone may have COVID, that you start isolation. So the first thing is to start, prevent the disease from expanding or affecting healthcare workers or nosocomial transmission or other patients. But the second thing there was identify if your patient is sick. Do they have severe disease? Do they have complications? And if they do, then start to treat them. And that decision-making process is what is so important when you take care of patients who are critically ill, is that you identify them early and then you start the supportive care treatments that you do have available. So what do we have available? Oxygen. So the correct use of oxygen, both that it's available and accessible and it's used correctly, then can save lives. That was the first thing the first message we had to bring was find your patients who have severe disease, bring them to the hospital before they get very sick at home and start, the supportive care treatments that are needed. Some of those patients, a small percentage of those patients do advance and needed more advanced respiratory support, such as invasive ventilation, high flow nasal oxygen, non-invasive ventilation. And we've been learning a lot about this, actually, which advanced respiratory support device is better for these patients. But what we did know is that once you get into critical care, unfortunately, there has been high mortality rates in some countries in ICU with, many patients dying and others less so. So what is making it safer in critical care? I think it's using good care bundles in critical care, knowing how to use the ventilator in the correct way. So these are not things that are just exclusive to COVID. It's actually best critical care practices that you can take from other diseases and apply them to COVID. So I think that's what we've had to take into place. So until there is, a life-saving therapeutic, although I have to say right now, we do have something that does save lives. And let me repeat that. We have the corticosteroids. So systemic corticosteroids has been shown to reduce mortality, save lives in patients with severe and critical COVID. So that's good news. So we have that drug that we can give, and it's widely available, and it's cheap, and it's can be given safely to patients. The other aspect of what I think clinicians and health systems needed to understand that it's not just an infectious disease doctor problem, right? So this is very clear that every clinician needs to know about COVID-19, from primary care to infectious disease to emergency physicians to ICU physicians, to rehab doctors, right, to reduce the the post-COVID symptoms that some are functional limitations that patients may suffer. So this is a multidisciplinary approach, the cardiologist, the neurologist, and so now we're looking at COVID-19 not just as a primary respiratory disease. We know it affects other organs. And so the team that takes care of the patient in the hospital has to be a multidisciplinary team and work together to give the best care for that patient. So it's the staff, the structures, the design of your facility, the availability of oxygen. I think, there's always been a concern about availability of oxygen in some of the most resource limited settings, that there would not be enough oxygen to give to patients. And we've seen that in some settings where the oxygen availability is limited, and trying to scale up the production of oxygen in order to give enough to the patients or to use the ventilator. So that is an important structural issue that is a priority as well for countries. And then just having the system in place, the referral system. So we like to think about the staffing, it's ready, the structures are ready, the design in the facilities is ready for IPC, and making sure that you can keep everyone safe.
Currently, we have a situation where you can see that in many countries, fatigue has set in. You earlier on advised in terms of what we have to do as ordinary people in terms of ensuring that we don't see the spread. And people were quite committed earlier on because they were shocked and they were scared. But it looks like now it's business as usual, particularly the young people.
I mean, for me, it's vigilance, it's commitment to the cause. I mean, there is so much that we can do and we must do and we need to do together that we can end this. I mean, COVID is going to be with us for quite some time now because the virus is in many different countries. And we keep hearing us say no one is safe until everyone is safe. But in putting that message out, that means that there is a lot that we must continue to do. The biggest message is that this is a virus that can infect any of us. It has been shown to infect young people, older people. It is not just a disease of older individuals. It is not only affecting older people or people with underlying conditions. We have seen many young people infected with this virus end up with severe disease in an ICU. We've seen children die from this disease. So it isn't just something that is affecting someone else. All of us are involved in this, and all of us need to play a role in it. So I think keeping up the momentum, knowing that this is something that we are going to need to live with so that we can find ways to suppress transmission, really bringing that down. And all of this comes, the way that we can do this relates to how we live our lives. How we go to work, if we could walk to work as opposed to take public transportation, if we can order out instead of going into a restaurant, if we can telework. In many parts of the world we can, but in many parts of the world we can't. It's making decisions that prevents the opportunity for this virus infecting us. Avoid it in closed, crowded settings, especially settings with poor ventilation. Opening up the windows when you're indoors. Wearing a mask in the areas where you're asked to wear a mask, especially in enclosed settings, especially where there's poor ventilation. All of these things matter. But we need to find a way that whatever it is that's going to motivate you to keep you safe. The strong message is that all of us have a role to play. You have a responsibility not only to keep yourself safe, but to keep others safe.
I think everyone, even if you've had the infection, still has to follow exactly what Maria just said. That you have to follow strict infection prevention and control interventions, strict public health interventions, hand washing, social distancing. We do not understand enough about the immune response to COVID-19. So there's no reason just because you've had it once that you're not necessarily at risk or I don't know if you want to add on more.
Yeah, it's also yes. So there's a lot that we're learning about the immune response. And so when people are infected with this virus, they develop an antibody response 1, 2, 3 weeks later. And people, even with asymptomatic infection all the way through severe disease, are developing an immune response. The issue is we don't have a complete picture yet of how strong that immune response is and for how long it lasts. And with more than 40 million cases reported to date, we have some instances, about 24 examples of reinfection. So that tells us, even though it seems to be rare, it can happen. And so everything that's been put in place needs to remain in place with all of these measures. But it's also a show of solidarity. So even if you have been infected, making sure that you keep your distance, that you avoid these crowded settings, that you wash your hands, it's a show of solidarity. This is our new normal. Our new normal includes washing our hands regularly, carrying an alcohol-based rub, keeping physically distant from others while socially connected, avoiding in crowded places, making smart decisions. All of us need to continue to be our own risk manager and make these decisions that are right for us. If it doesn't feel safe, don't do it. So all of us are in this together.
Well, I have to say it's quite refreshing hearing from other people from the WHO and not the consistent voice that has been coming from Dr. Tedros. Dr. Jeanette Diaz, who should probably call herself Dr. Diaz III, as well as Dr. Maria van Kerkhove, in conversation there with our foreign desk editor, Sophie Mokoena.